Well, good afternoon, everyone. I think we will start our program now. I'm Tim Ritchie, the president of the Museum of Science, and your host this afternoon as we discuss one of the most important issues of our time, the COVID-19 vaccination and our collective ability to emerge from this global public health crisis. Today, we just received the terrible news that over 300,000 Americans have died from COVID-19. We're at a moment, though, where we do see hope. COVID-19 vaccines are emerging and taking their place on the world scene, but many questions remain. How safe is the vaccine? How effective is the vaccine? Who will take it? Will it be accessible to all? Will people be willing to take the vaccine? These are the questions our whole community has. And so we, last month, in participation with the Massachusetts League of Community Health Centers, commissioned a survey by Mass Inc. polling group to understand and to hear from Massachusetts residents about their willingness to take the vaccine and about who they trust when it comes to communications about the vaccine. What emerged is an optimistic message of willingness to take the vaccine once it's available, but there are caveats. There are exceptions, and these exceptions offer clear action points for communications, for policy, and for action to build confidence in the vaccine. I'm honored to welcome some of our region's top minds today to discuss the challenges and opportunities in the vaccination process. This town hall is a part of the museum's effort to convene the community in discussion around the coronavirus and around the race to the vaccine. Through digital and in-person exhibits and public conversations like this, we aim to amplify the work of our trusted experts while listening to you, our community, to understand your concerns, to hear your ideas, to share your priorities, and to understand your values. A couple housekeeping notes for today's program. If you have a question, please use the Q&A box located at the bottom of your screen. We'll try to get to as many of your questions as possible. And for those of you who want closed captioning, please click on the closed captions button and select show captions. It's now my pleasure to introduce the president of the Mass Inc. polling group, Steve Koczela. Steve is the president and the founder of Mass Inc. Polling, and is nationally known and is a respected polling provider. Prior to founding Mass Inc. Polling Group, Steve led survey research programs for the U.S. Department of State and was the polling director in key states for President Barack Obama's 2008 campaign. Steve frequently appears in local, state, and national media outlets discussing polling, politics, and policy. Steve oversaw the facilitation of this poll, and we're pleased to have him today for his insight on what the poll tells us. Steve, can you please lead us through the poll results and the top line implications as you see them?
Excellent. Thank you very much, Tim. And it's a pleasure to be with you all this afternoon / evening. You should now be seeing on your screen a very brief series of slides that we're going to use to go through the results of this survey. So to begin, I'd just like to tell you just a few things about the survey. First of all, as Tim noted, it was sponsored by the Museum of Science with a big helping hand from the Massachusetts League of Community Health Centers. And if you have any questions at all or want to see a lot more, there are a lot more results that you can look at, question wording, crosstabs, more slides, all kinds of stuff over at our website at massincpolling.com. So I just suggest you take a look there. The survey that we're going to be talking about is one that we ran in mid-November. It was a survey of 800 residents statewide. And then what we also did, and you'll see what we were able to do with that in just a bit, is we did oversamples of 250 each of Black residents of Massachusetts and of Latino residents of Massachusetts. And that's important because it let us really dig into some of the demographic differences that you'll see as we walk through the results today. Go ahead and move on to the next slide if you would. Okay, so the big question, the question that lots of polls were asking and that we asked on this poll was the very basic: how likely are you to take the vaccine when it's available? And we see 44% say very likely, which when you just stop right there and just look at it, doesn't sound very good. Obviously we need more people to take the vaccine if we're going to get to where we need to go. But what we realized was that there's more to it than that. It's not just likelihood. There's nuance to what people actually mean when they say likely that gives us, I think, more cause for optimism than if it were only 44% who meant I'm going to take the vaccine. But it turns out that's not exactly what they meant. And the next slide shows what I'm talking about. On the next slide, what we asked was, when do you think you would be most likely to take it when a FDA-approved COVID vaccine is available? And what we see here paints a very different picture. Here we see a lot of people, 36%, saying basically as soon as possible, as soon as they're able to take it. But then we also see in the middle two bars here, about half of the people say, I do plan to take it at some point, but I don't want to be the first one in line. 19% say they would like to take it after a few people I know have taken it. Another 28% say after many other people have taken it. And you're all the way out to the fourth bar before you get to just the 7% of all respondents to the survey said, I'm never taking the vaccine. Whereas when you just ask about likelihood, which is what we saw in the previous slide, it tends to sound like if you say I'm unlikely to take it, you tend to think, well, that means they're never going to take it. But when we kind of look at these two things in tandem, which is what we did on the next slide, what we see is that the people who said they were very likely, the thick bar there on the left, 44% of respondents, when you break those people down by when they say they're going to take it, what we see is that likelihood, when people say they're not going to take it, what many of them mean is they just don't want to take it yet. They want to wait a little while. Your very likely group, most of them mean they're going to take it as soon as possible. But even among that group, some of them do want to wait a little while until a few other people that they know have taken it. Then you move out to the somewhat likely group, the group that that seems perhaps a bit more tenuous or a bit more hesitant. And there too, you see most of them, in fact, nearly all of them do plan to take it at some point, but more of them want to wait until other people they know have had a chance to take it first. And even the people who say not too likely, the next bar, even them, most of them mean that they still want to take it, just not perhaps quite yet. It's only when you get out to the not at all likelies, which is a pretty small percentage of the overall population, just 10% of the population, where most of them mean that they're never going to take it. But if you just look at the size of the red bars compared to the entire picture, you can see that that's really not a huge swath of the whole population, which is kind of what was one of the central insights of this survey. We've also seen this echoed sense, excuse me, in a Boston Globe survey that was released this weekend, where only 12% said that they were unlikely to take it, and we saw, or were going to never take it. And we also saw it in some national surveys where where when you ask this question this way, it is actually a much lower number than the one we've been talking about. So then if you go on to the next slide, there are some key things when you kind of dig underneath this. One of them is when you break those same numbers we were just looking at down by who plans to take it sooner versus who plans to take it later, there are big differences and big disparities in kind of how this chart is laid out. And just to quickly orient yourself to it, the thing to do is just look at kind of who's at the top of this chart, what demographic groups are at the top of the chart, and what demographic groups are further down. And you can see that those red bars there, the ones sticking off to the right, that say they're planning to take it sooner, 75% of people with advanced degrees, 67% of white residents with college degrees, and just kind of get a sense of who's up there at the top. You can see that there are big socioeconomic differences in terms of who is planning to take it first versus who would prefer to wait a little while. And there are lots of reasons for that, which is going to be an important aspect of the conversation for the rest of the evening. But the thing to kind of take from this is that if we just sort of let everybody queue up, so to speak, there would be big disparities in terms of who would be eager to be in the front of the line to receive the vaccine. So then the next couple slides, what we looked at was who people want to hear from. Who do they want to hear from to know that a COVID vaccine is safe and effective? The number one group at the very top, people said, my own personal doctor. There we found about 80% said they either completely trust, which is your dark red bar there, or mostly trust, your sort of pinkish bar, what their personal doctor would say about that. And then we see a collection of medical organizations, scientific organizations. Dr. Fauci's up there, and the Museum of Science you see up there. And then further down, you see state government, political officials and political leaders and faith leaders, and you see President Donald Trump down there at the bottom. But basically the thing to take from this is that first and foremost, it is the doctor that you know the best, your own doctor, and then it's scientific and medical organizations after that. So what do people want to hear about is what the final slide that we're going to show today is. What are their main reservations? And I think the thing to take from this is that the main reservation, I think, is linked to the desire to perhaps wait a little while that some people express. The number one hesitation people have is that there is concerns that the vaccine has not been thoroughly tested. And we see 65% of respondents to this poll said that that concern applies to them either strongly or somewhat. And then the number two concern, which is the only other one that got a majority, was people expressing reservations about trusting the government on healthcare issues. There are some other ones that are reasonably widespread, and there were some differences by demographic groups, but overall, those were the top two concerns. And I should also say that although there are some differences further down, the top two concerns are shared among most demographic groups and are shared among those most hesitant to take the vaccine, and also the communicators that are the most trusted, which we looked at on the previous slide, that view is also held in common by even those who are most skeptical of the vaccine. So that is a very quick and very high level overview of the main things that the poll said. Again, all the results are posted both on the Museum of Science website as well as massingpolling.com. And I look forward to taking some of your questions a little bit further on.
Steve, before we move on to the panelists, there is a quick question. Is there somewhere that people could find similar published data for a national scale or for other states in a nuanced way like you have there?
Yeah, there is one poll that I just saw come across today from ABC News and Ipsos that asked a similar kind of question and found a result that was on a similar scale. I have not seen anybody kind of aggregating it all, to be honest, to sort of show what all the different pollsters are finding, but just one specific poll that kind of looked at it the same way. The ABC News Ipsos poll is one that I just saw today. There may be others. That's just the one that I happen to notice today.
All right, thank you. And for those of you out there, please do send your questions to Steve about the poll in the Q&A section, please. And now it's my pleasure to introduce our panelists. First, Michael Curry. Michael Curry is the incoming CEO of the Mass League of Community Health Centers, and he's also a member of Governor Baker's COVID Vaccine Advisory Board. Michael worked for 16 years at Blue Cross and Blue Shield of Massachusetts as a senior policy advisor and has served on the health care transition teams for Governor Deval Patrick and Mayor Marty Walsh. He was also involved in the passage of Massachusetts health reform and the Affordable Care Act. Michael is the past president of the Boston branch of the NAACP and has served as member of the National NAACP Board of Directors, where he served for 6 years. Rena Conti, PhD, is Associate Research Director of Biopharma and Public Policy for Boston University Institute for Health System Innovation and Policy. This is pharmaceutical policy. She was also the co-chair of the Pharmaceutical Policy Committee for the Biden campaign. Dr. Conti works as a health economist, and her research focuses on the organization, financing, and regulation of medical care. She has written extensively on pricing, demand, and supply of prescription drugs, and most recently on COVID-19 vaccination. So welcome to you both. All right, Michael, the first question is for you. People of color seem to have a deeper distrust about the vaccine, and there are good reasons that they do. Would you talk about some of the reasons for this trust and comment on what you believe the path forward is to building trust?
Thank you, Tim. I want to start by saying thank you to you, the Museum of Science and Mass Inc. for the work that was put into this poll. And thank you for inviting the Mass League to be part of this. I think as I just got off of a DPH state, actually a state call around the receipt of those first vaccines that were delivered to Boston Medical Center today, and discussing the packaging and all the detail that's required for providers distributed. I thought about the poll, and the reality is that all the providers across the country, and particularly here in the Commonwealth, will be looking at our poll to figure out how to distribute this vaccine, how to make sure that people actually are receiving the right messaging. So again, want to credit you, Tim, and your team at the Museum of Science, and Steve for the great work that Mass Inc. did and always does. That being said, Tim, I think to your question, we have the taint of race in our healthcare system here in this country that we've not really come to terms with, right? So part of it is understanding the history. We tend to get to the conversation of distrust in our criminal justice system, our education system, or our healthcare system, but we don't, it's all ahistorical. So the reality is, let's start looking at the taint of race during slavery in our healthcare system. And that conversation would start with J. Marion Sims and the experimentation on slaves, and then many others. It would walk through decades post-slavery that African Americans were denied access to healthcare, were denied entrance into our healthcare institutions for much of our history until Medicaid, Medicare forced the integration of our hospitals and many of our healthcare systems. That's history that people don't know. They may not know about the Tuskegee syphilis experiment, that 40+ years that those men, Black men, were brought into an experiment that was not about treating their underlying illness, their stomach pains, their illnesses that they were being told would be treated through this experiment. This Tuskegee syphilis experiment was unethical and happened for over 40 years. So I think that's where we need to start, is having a reckoning on our history of race in medicine in this country. Then we get to why we're here. The Institute of Medicine in 2002 put out a report called Unequal Treatment, that Black and brown citizens weren't getting the same health care as other Americans. And that was not just because of what we eat and where we live, it was also because doctors weren't treating us the same. We now know we're not as often integrated into our clinical trials efforts. And the absence of us means that the data, the outcomes, do not speak to our illnesses. So that was a conversation in COVID-19. And there was some intentionality to make sure that we had Black and brown patients in those clinical trials. That all being said, there is a legitimate reason that if you're a Black and brown, adding on the issue of the anti-immigrant policies in this country that are playing out, that brown citizens and Black citizens who are immigrants and others are not coming in to be tested and traced and cared for when they're ill, and now may not come in for a vaccine because of some fear about our immigration policies. We have a legitimate issue. And the messaging of this is we have to direct our messaging to those communities. Speak to the science, speak to the data, speak to the efficacy, speak to the fact that we need them to have access to this vaccine, because those communities are disparately impacted, 2.5 times more likely to get this disease. 22% of the Black of those who are dying of this illness, representing those populations. So it's a lot that we need to deal with. Tim, to your question around how do we address that? It's all about messaging. I know that people are reaching out to me, our foundations, our government entities are saying, how can we partner with you, Mass League of Community Health Centers, hospitals, other providers, so that we can target our messaging to reach communities, that we can answer their question while we also acknowledge the past. And I think, Tim, I'm encouraged because your survey, our survey, has really pointed out that people are likely to take it if they get the information that they need.
And then let me just ask you a quick follow-up, because one of the things in the survey that did not ring true to me was that only 12% say they would trust their family and friends about the vaccine. I wonder that a little bit, because it seems to me that the poll also shows that I will get the vaccine if someone I trust gets it first. So partly, I wonder if we could unpack that a little bit in communities of people of color where, yes, it's important for the doctor to say it's okay and to get the vaccine, but I wonder if there's also a social proof element here where if someone like me gets the vaccine, that I will trust it as well. Can you comment on the role of community, of people like me getting it first, giving them confidence to take the vaccine as well?
Well, I've been on many calls with the doctors, the epidemiologists, and as with the work with the COVID-19 vaccine working group with the governor. And again, credit to the governor and Secretary Sutters for the work that they did to convene this group. I think what's in that result, Tim, is that people aren't waiting on someone else to tell them it's safe. They're waiting to see if it's safe.
That's right.
So part of what we're seeing is adverse reactions, right? We know that there's adverse reactions to the seasonal flu, but people are waiting to see, hey, I want to see if other people take it. And if they have, as we know, I think the data says about 50% of those who take it have some temporary adverse reactions, and then they recover and they're able to, if they take the 2 doses, not contract the disease, or at least not get ill from the disease. People are waiting to see what other people do. If they take it, how their body reacts to it. But ultimately, the great news in this survey that I don't want us to lose sight of is that there's a cascade of people that people trust. And Fauci's on that list, our government agencies on that list. But it goes back to the number one people we all defer to, which is our primary care providers, our doctors. So if you have an illness and you go into your doctor is giving you the course of treatment. If you go for surgery, your surgeon is giving you the course of treatment for your surgery. We have to go back, and people are saying in this survey, we trust our doctors, and then we trust our hospitals, our health centers, the Museum of Science, and so many others. We need to all in concert start delivering that message that the vaccine is here and we need to get to herd immunity.
Thank you. And that's a great segue over to you, Rena Conti, Dr. Conti. Rena, there are 3 big issues, of course. Is it safe? Is the vaccine safe? Is it accessible? Can I get it? And as Michael was saying, is it effective? The efficacy. And this is something you've written about, you've thought about, you've talked about it, you have some creative ideas. Can you lead the people who are listening today through the issue of efficacy? And then maybe some of your ideas on how we can demonstrate efficacy to the wider community.
Yes, and thank you so much for having me. So I like to think of this as we have a supply problem. Are we going to get vaccines, and when will we have enough scale to vaccinate our population and the rest of the population as well? But then we also have this demand problem, and the demand problem we are now just confronting, we're identifying it, we're trying to understand what its contours are, and ultimately we're going to have to find creative, bold, systematic solutions to it, just like we've done with getting vaccines to come to fruition to begin with. So the vast majority of the government's effort in the rolling out of these vaccines is ensuring that there is safe, there's enough supply, and supply going to providers that can handle the physical requirements of these vaccines. The other component of government action is imposing a lot of constraints on the companies and the medical providers to assess the product's efficacy, or really their safety. In other words, how safe is it? We are having some side effects that have been reported. Some of them seem a little severe, but very rare. We want to make sure that when we are pushing this vaccine out into the general population, it's being used in populations that were really never tested on. In the phase 2 and phase 3 studies, we know how safe these products are. But then we have to get to efficacy, and there are a variety of different parts of efficacy. One is adherence. The 2 vaccines that we are aware of right now are a 2-dose regimen. In other words, you have to get 1 shot, and then you have to wait a little bit of time, and then you have to get another shot. It's only when you get that second shot do we believe that you are protected from being infected. we don't know what the conversion rate is going to be. In other words, how willing are people going to be to come back and get that second shot? One of the things that we've seen in the press and that the companies have, press releases have also alluded to, is that that second shot, that booster shot, appears to be related to having people reporting more side effects. They're tired, they may have a fever, they may feel achy, and therefore they may not be able to come into work. They may not be able to do the things that they normally do. And so it's not just watching your peer group get the first vaccine or the first dose, it's watching your peer group, your friends, your doctors, and the evidence come in saying, okay, when I get that second shot, I feel okay. So that's a very important part. The other parts of effectiveness are also really crucial. One is duration of protection. Another is related to all the other endpoints that we know really matter to people, like, can I go back to work? Will I have reduced hospitalizations? Will we see reduced deaths? Will I be able to interact with my friends, my family, and get back to normal? All of these things have to be assessed both in very specific patient populations, like the ones that we saw in the trial, but also nationwide, and including some very vulnerable patient populations and populations that aren't the most necessarily willing to get out in front and be vaccinated now. And so what do? Well, we need an all-in strategy that's creative, that's systematic, and that really meets people where we think the hesitancy and the concerns lie. There are a handful of creative ways, but I would say they generally fall into two buckets. One is information. Surveilling people, surveying people, asking them questions once they've gotten the first vaccine, and being willing to monitor them afterwards. Some of that can come certainly from physicians and other medical providers being engaged with their patients over time. They can feed that information back to the companies, but also to the government. The second bucket of interventions related to efficacy or effectiveness is money, which is simply to engage people by lowering barriers to access and maybe even paying or finding other creative ways to get people engaged in this process and willing to report not just whether they had certain side effects, but also all the other behaviors and other things that we really think are important. Myself and my colleagues proposed last week that we have engage in a really fun and exciting lottery where we actually paid people to come back and get that second dose, and also come back and provide information about all those other outcomes of effectiveness that we think are really important.
I would love to talk more if we have more time on this lottery idea. It's a really, really creative idea about making the whole thing transparent and public and accessible. I think the thing that you were saying, though, Rena, is very important for the Commonwealth and the rest of the country to realize, is that this is not going to be like the polio vaccine, where you get a shot, where Elvis Presley can go on the Ed Sullivan Show in 1956 and get the shot. And it's a complicated process that's going to require a certain kind of nuance and a certain kind of trust in science. And this is a complicated issue right now. I'd like to get to the trust issue again and get back to one of the more difficult issues. One of the listeners has written a question about trust in the government and a challenge with innumeracy in our country and just how nuanced this conversation is. I'm going to take it back to you, Michael. When you hear about the complexities that Rena has talked about, you hear about the hope that people have for a quick fix because they've seen a quick fix with polio. How do we as a community come together to deal with this complexity, to deal with the distrust people have in government, and band together somehow to walk through all these complexities? There was one idea, of course, about the lottery, which is creative and interesting. At the community level, how do we walk with each other to be patient, to do what we need to do, to take both vaccines if necessary?
Tim, I think as the poll points out, people have a distrust that we got here so quickly. And I think that's normal. I think that that's not an American distrust. That's probably a global distrust. And we have to speak to that. I think as Dr. Conte and so many others that I've gotten a chance to work with on the COVID-19 working group, people have a heightened consciousness of the science right now, Tim. And they're paying attention in a way we've never done before, probably not since the polio vaccine. I would probably argue even more so now, today, because we have so many ways to reach people with social media. So I think right now there's an opportunity to lift everyone's consciousness on the CDC's process, on the FDA's process, on the really smart scientists. You know, I told a friend of mine the other day who had a lot of distrust in this, and I said, you know, when you went in to get that hernia operated on, how much did you understand about your hernia operation? Or did you go in and you put some trust, you put some deference in the fact that that doctor was going to do what he or she needed to do to treat your hernia? That's true when we have diabetes or heart disease or cancer. The same is true with this vaccine. We need to ask critical questions. And I think about the poll, it talks about the low numbers of trust that exist within pockets of the community like Black and brown folks and women, Black women in particular. And the way I describe that to people, if you go to my mother and you tell her that you need me to take a vaccine, she's gonna ask you some tough questions. She may not understand all of the lingo, the semantics and the words, but she's gonna ask you some tough questions because she wants to make sure her baby's all right. And I think we gotta speak to people like my mother and boil this science down in a way that's digestible, that people can take it in, and then say, okay, it's worth me taking this risk, because the other side of that, using my mother as an example, is that she has more than 2 comorbidities, that she's at a heightened risk, that she's seeing many of her friends and family members sick, and even some dying of COVID-19. So we know there's an urgency for her and for many like her across this country, Dr. Conte. So we have to speak that to them.
I agree.
But the science starts first. And I think the work that you're doing, Tim, with Mass Inc., the work the governor's doing with the COVID-19 working group, and then on the national level with the incoming administration, sort of lifting up everyone's consciousness about what this is going to make a difference.
So I'd like to pick up on both of these points and come back to you, Rena, about money and about investment. The investment in this vaccine itself was unbelievable. The amount of government money that went into developing the vaccine, Operation Warp Speed, not only in this country, but around the world. I wonder about the other levers, economic levers we can pull right now to encourage, from a market standpoint, the uptake on the vaccine. And in particular, two issues, and maybe you can address them both or take them one at a time. One is the role businesses will play and whether they should have indemnification if they encourage their employees to take the vaccine. So the role that businesses can play and the role of indemnification, if you could break that down for our listeners, that'd be great. And the second thing is the role that insurers play and the relationship between, but insurers are going to play a huge role here, just as the government had to have massive investment to create the vaccine. We have to have a few other economic levers to result in it and people taking the vaccine. So can you address both the indemnification issue and the issue about insurers?
Sure. So we live in an economy that is multifaceted and has both public or government players and private companies, including private insurers. I would say it is crucial to make sure that people understand that getting access to these vaccines will be completely covered by insurers. Whether or not you are publicly insured or private insured, you will get access to these vaccines and you will not have to pay a penny out of pocket for them. And that is true whether you go down to your local pharmacy or you come into your medical provider. It will all be provided free of charge. That messaging needs to go out. People need to really understand what that means. And people also need to understand that getting a free vaccine doesn't entail any stigma. We've seen in the past that sometimes people will assume that if you're getting a medical good for free, whether it be preventive screening for, I don't know, colorectal cancer or breast cancer, or other types of preventive health, that people sometimes don't completely understand or feel like they're getting something that might not be valuable to them. It is so valuable that we want people to come in, ask questions, ask their pharmacists, ask their medical providers, engage with the community, and not pay anything out of pocket. The other thing that I think needs to happen, or that we're seeing a national conversation around now, is what will the role of employers and other businesses be? And there are a couple of ways that this can happen. One can be that each of our employers can force us in some way to be vaccinated. They can make our employment conditional or practically conditional on vaccination. That in the past has not worked that well. So for example, mandatory flu vaccines don't actually work very well in the widespread community. This is a vaccine that's going to have a lot more questions around it than flu. And the other thing that you should know is that employers don't have indemnification. So if something happens while you are after you've gotten vaccinated, your employer has made you get vaccinated, and then you have an effect that is negative, employers could face lawsuits attached to that. And so that's made some employers very skittish to pursue mandatory vaccination or practically mandatory vaccination. The other way of doing this is to make our engagement in certain types of activities that we really value contingent on being vaccinated. So in other words, going to a restaurant, you're going to have to prove that you've been vaccinated or prove that you have immunity in some other way. We heard Qantas, the international airliner company, announce a couple of days ago that they're thinking about requiring people to show that they have been vaccinated in order to take an international flight. These type of activities, they're not monetary payments, but they are some sort of inducement for people to get vaccinated or otherwise become immune.
Yeah, those are the kind of economic levers I was talking about. So thank you for that. Steve, I'm going to bring you back up if you'll put on your camera again. There's a couple other little questions about the survey itself. One I think is pretty straightforward, and I'll just give you both questions. Surveys lump all COVID-19 vaccines together. Obviously there are many, so did you lump them all together? That's number one. And then number two, how do the polls compare with other polls in the UK and the European Union?
Yeah, the answer to the first is yes, we did. We did lump them together. Certainly there, will be differences, but we try to keep, in any technical issue that we're polling, we try to keep things at a level that the survey respondents will understand. We try to keep the science sort of at a basic level, or policy at a basic level. The question about other countries is a good one. I actually am less familiar with the surveys that have been done elsewhere, but if either of the other panelists have seen other surveys that have been done elsewhere and how they compare, I'd certainly be interested to hear more about that exploration, or we could look into it and provide some information later on.
Yes, and if any of our viewers happen to know as well, we could hear from you in the Q&A function. I think I'd be interested in that too, given that there are probably some differences per country on how people approach trust in science communication, trust in science generally, but you never know till you actually ask the question. So if anyone knows the answer to that, Michael or Rena, and if not, we can ask our listeners to help us, which they no doubt will. I want to ask a very kind of aspirational question of you, Michael, and you, Rena, both. When you think about the development of this vaccine, it was breathtaking. Global cooperation, global investment, new technology, an unbelievable number of people that people could be tested on. So we got to the finish line, so to speak, very quickly, and it was a breathtaking achievement. And I think it would be natural to sort of take a deep breath and think that, you know, we got to the finish line. But really, of course, we got to the starting line because vaccines don't matter. Vaccinations do. And I wonder if we could be aspirational for a second between the market levers, perhaps, that you were talking about, Rena, and the community things that we want to talk about. How can this be actually our finest hour? Not so much the production of the vaccine, which was a technological triumph, but how do we use this moment really to re-engage and care for each other in new ways where everyone is able to take the vaccination? What do we have to do for us to go from a community that thinks so much about individual achievement or technological achievement to binding together as a community so that everyone can take this vaccination and we can get back not only to maybe business as usual, but maybe actually a better community? Michael, can you dream a little bit on that?
Yeah, but before I dream on it, Tim, because you and I have had this conversation, I think something's fascinating about it. So one is we know that it wasn't a matter of if there would be a pandemic, it was a matter of when. And I teach a course at Suffolk University, and I always tell my students, we have to prepare for it. I think about Ebola and what happened under our prior administration of really responding to Ebola, getting over to Africa, having the boots on the ground, the resources to look at the spread of Ebola, what it meant, and how we could prevent it from really traveling across the rest of the globe. There's no rocket science into this. And I think Dr. Conte and many others who do this work can tell you there's a boilerplate, there's a template for this work. Where we sometimes go wrong is we don't follow the template, the playbook. So I think about Ebola, and the unfortunate part about that is when disease is in certain parts of the country or certain neighborhoods, or they impact certain people, we don't respond the same. And the reality is we need to, because disease anywhere could be disease everywhere if we don't respond to it. I think Ebola was a lesson plan that we should have paid attention to and it prepared us for COVID-19. I think to your question, what I'm not excited, but I'm encouraged by, to your point, is that we worked across boundaries, across governments. Dollars were made available. Governments put up dollars. We were sharing science and sharing information in a way I don't know if we've ever done. But what it says is if we can do that going forward, we can solve other stubborn diseases that take lives, whether they impact the whole globe, whether every country bears the impact of a disease or not. If we all put up our resources and our science and the intelligent people in our communities who do this work, we could solve some other pretty devastating diseases, even if they're impacting parts of the globe that no one knows about right now. So I'm encouraged by that, and I'm hoping that we don't lose the playbook, because between the administrations, we tend to forget that the playbook exists. That's what I'm hopeful for, is that playbook will stay on the White House desk going forward.
All right, Rena, what about you? Can you dream with us? How are we going to get from here to there and make it a fine hour for us as a nation and as a world?
Yeah, I mean, for me, the key is equity. This is a moment where we are confronting an infectious disease, and no one can be left behind. We cannot have wells of this infection in people in prisons, in people who are undocumented, in people who don't have health insurance or don't have a regular source of care. That will not get us back to our lives. So the real engagement has to be that everybody has to get access to this vaccine and to all of the other mitigation strategies and other therapeutics that if and when we become ill or one of our loved ones becomes ill, they also will gain access to the therapies that are existing and are coming as well. And so I think engagement with communities, but also meeting communities where they are, and giving them the resources that they need in order to engage in this process and get back to our lives is a Herculean task, but it's one that we are ready for. But that it is really going to take all people, all hands on deck to get to move forward.
You know, you make an interesting point. You could almost be articulated as enlightened self-interest, that until everyone gets the vaccine, until everyone is COVID negative, no one is safe. And so even if we only think of it in terms of self-interest, we should make sure that everyone gets the vaccine, which takes me back to you, Michael, and your role on the governor's panel, because the panel for distribution of the vaccine came up with some priorities that have surprised people. I've heard people talking about it. Why should these people get the vaccine? So the panel came out with favoring people who are incarcerated, who are homeless, who have 2 comorbidities, who are undocumented. These are where Rena was talking about in terms of everyone getting it. But you can imagine this goes even beyond what the CDC has recommended. Can you take us a little bit into the conversation about how the Commonwealth of Massachusetts came forward with such a, frankly, breathtaking view about the distribution of the vaccine?
Thank you, Tim. I think of, I always make a spin on Congresswoman Ayanna Pressley's quote that she's known, one of the quotes she's known for. And I'm going to use a different version. She says, I would say, those closest to the disease need to be closest to the vaccine. And the reality is, those were really core parts of that conversation during the last several months of the working group, Dr. Conte. People were sitting there saying, okay, but what about equity? How do we reach those communities most impacted? How do we save our healthcare workers that are, quite frankly, on the front lines? And as we prioritize them, tend to make them first to get the vaccine, people might challenge that, but it made sense because ultimately we need them on the front lines saving lives. We know that this fight against this disease will take place for most of this upcoming year, and that we may see other surges. So we need those doctors, those nurses, those other medical staff, those community health center providers at their post, quite frankly, treating patients. So that's one. I think to your question around populations, whether we're talking about the homeless population or long-term care, or quite frankly, those who are incarcerated, our policy reflects our values. And if I'm proud of anything to be in Massachusetts, we do things differently in Massachusetts, right? Thanks to the CDC and the ACIP, the advisory panel that was put together, and they gave us some high-level guidance, but we do stuff differently here. And the reality is that table, or virtual, because we weren't sitting together, included some really powerful people who bring equity and justice to the conversation, like Liz Walker, Reverend Liz Walker, like some Black and brown physicians and providers, and others of good conscience with a good compass around this work, like Dr. Conte, who sat there and said, but what about those communities most impacted? What about the fact that people are incarcerated and are higher risk of dying of this disease because they're in these congregate care settings? That's the reason, Tim. And I would imagine, just like health care reform in 2006, we did it a certain way, other states will follow us.
I'd like to pick up on that maybe from the, once again, the insurance side arena. We are an unusual state in that there is nearly universal health insurance. This is rare in our country. What should policymakers make of that in terms of this poll where it says people will trust their doctors? We have nearly universal healthcare here. So how do we combine those things to get at this idea of everyone being treated? Maybe it speaks for itself, but it does seem to me that pulling the insurance lever, even if it's public insurance, is an important part of the answer here.
Yes, so with near universal health insurance, again, cost should not be the barrier, but there are so many other barriers, which include information. It includes just frank fear. and misinformation that's going to need to be overcome. And then many people have to choose between taking a day off of work or 2 days off of work to come get vaccinated versus taking care of their families who, schools are closed. Many people are home with their children, or have to go to work. And so those type of decisions or those type of trade-offs are real. And it's exactly in the communities that are most at risk where those trade-offs are going to bind the hardest. And so finding ways to make it worth people's while, to take that day off of work, to find someone to take care of your child so you can get vaccinated, or bring your child to be vaccinated, or bring your mother to be vaccinated, ultimately is going to be what it takes here, and certainly something that I think the state's going to have to address. The incarcerated population is a separate population, and one that faces a lot of challenges in terms of gaining access to healthcare, gaining access to needed services, not just for COVID vaccination or prevention, but for so many other services as well, that again, I think the Commonwealth is going to have to contend with.
I'd like to stick with you a little bit on the federal side. Since you were an advisor for a while to the Biden campaign, we will have a new federal government. What role do you anticipate, if you had a crystal ball, that this new administration will play in doing exactly what you said, that everyone would be vaccinated? Can you see a special role that this incoming president will play? Because right now it all seems that it's in the hands of the state, which is good for the state of Massachusetts. But we live in a country, right, that where everyone needs to be vaccinated as well. So do you have any inclination of where the Biden administration is going to go in advancing this matter of equity?
I think it's central. It's central to their strategy. It's been central to the commitments they've already made to the American public that vaccination will be made accessible to all, and that other resources that are going to be needed by the states, by the local governments, will also be provided. Similarly, they've committed to getting kids back to school, and giving schools what they need in order to engage the community to do so. So all of those things are important. Again, we need an all-in strategy, and I think the Biden administration has done actually an incredible job of articulating that we need an all-in strategy to get back to work.
Well, that would be encouraging, of course. One little note here, there was a question about what is the situation polling in other countries. You could Google this from the journal Nature, nature.com, about a global survey of potential acceptance of the COVID-19 vaccine. So you could get it there on Nature. I'm going to turn it back to you, Michael, for what may be our last question, but you say our policy reflects our values. I guess it would also say our actions reflect our values. So what are some actions that people who are listening today, there are still 354 people on this call. What are some actions that you feel like people could take that would reflect a value of caring for their neighbors enough to make sure that everyone gets vaccinated?
Tim, I think the number one thing is that we tend to deal in a lot of fake news in society right now. People don't know where to go get their information. And I even have my sons coming into my room every other day with something they got offline about the vaccine and misinformation. So I think as Pratt Wiley, who runs the partnership, called me today and he said, Mike, can we do something online, maybe have train the trainers, where you just train average everyday citizens on what the facts are, and then have them spread out on social media to spread the truth. And I think those kind of innovative, out of the box thinking around how we reach communities is where we need to go. So I would say to any listener on this call, we need you to do your homework. Don't just go to, as we call it in the law, forum shopping, where it sort of feeds what you want to believe about something, but go to where there's trusted resources. Go to the CDC, the FDA, go to the Department of Public Health, gather the information, and then be the source that we need you to be to spread that information in communities. there is some risk with taking any medication, with any vaccine. We can have an honest conversation about that too. But I think, as Dr. Conti and others will remind us, that the benefits outweigh the potential of dying from this disease and the fact that it is spreading. So I think we need to have those honest conversations, Tim, and I'm encouraged because people are calling me, emailing me, texting me every day, asking me questions, and I get out of the way because I'm not the doctor. I'm an attorney, Steve. We get out of the way. I connect them to people like Dr. Conti who can answer their questions.
Well, thank you for that. And we do live in a world where, unfortunately, 300,000 people in this country alone have died from the coronavirus. Coronavirus kills people, but we can do something about it. Average citizens who do something about it become citizen scientists. Everyone who wears a mask is a citizen scientist. Everyone who gets a vaccine is a citizen scientist. Everyone who talks to their neighbor about the efficacy of the vaccine is a citizen scientist. So it's our hope at the Museum of Science that this could be a fine moment for us as a community to use this public science moment to become a better community. On behalf of the museum, I want to thank Steve for the Mass Inc. poll, for Michael Curry and great partnership with the Mass League of Community Health Centers, for Dr. Rena Conti for all your contributions here. It is our hope that we do keep taking steps forward so that when the vaccine comes, all of the Commonwealth is vaccinated, and we can not only get back to maybe business as usual, but maybe become a better community at the same time. Thank you for joining us tonight on behalf of the Museum of Science. Good night.